Hello friends, welcome to Dental Excellence Academy. Today we are placing implant in maxillary anterior region, that is 1 2, and there is immediate placement of implant after extraction of 1 3. So this is the pre-op OPG for the same patient. So we have calculated the width and the height prior so that we can plan accordingly. So digitally we planned the implant so that our access hole will come on the lingual aspect of the crown. So this is CBCT for the same. So now I'm starting with the preparation of the site. With the betadine, we are giving scrub to the patient so that there should not be any cross infection. So we have injected the patient already. Now I'm checking for the anesthesia. So the anesthesia is working properly. So I'm starting with the crestal incision. So and now I'm giving clavicular incision. So I'm giving vertical incision in this case so that we can reflect the flap properly because we have to place two implants, and after placing the implant we have to pull the flap so that we can cover the implant properly. So that's why I'm giving vertical incision. So we'll be starting with the reflection of the flap. So, so you have to have a good instrument, a sharp periosteal elevator, so that you can reflect it properly. So now I'm reflecting the palatal flap. So with the lancet drill, I'm starting with the osteotomy. So can you see I'm parallel to both the teeth, that is central and the canine. You should be. So I'm checking for the length. This is 10 millimeter. So I'm using drill extender now so that I can go properly to the desired length. So my angulation should be from the palatal aspect to the buccal so that our access hole will come on the palatal aspect of the crown. So it is very difficult to go in this direction because we have a minimum amount of bone. So you have to be very cautious so that you should not perforate on the buccal aspect. So timely you have to check whether you are in the confines of the bone. So here the buccal bone is less, and now we have to go and check with the x-ray that whether we are going properly in the parallel direction to both the teeth. So now you can see we are almost parallel due to improper direction of x-ray. Now I'm placing the implant. You can see this is the iFix implant. It is 4 by 10 iFix implant. So I am going. It is almost. You can see it is almost parallel to both the teeth. So we are going to extract the canine. So we'll be correcting the direction for the canine. Now you can see I'm using a torque wrench and I'm getting almost 35 to 40 torque in this region. It is very difficult to get so much of a torque in the anterior region, but we have a good amount of bone. So see, we are getting almost 35 to 40 nm of torque. So can you see we are equicrestal on the buccal aspect and we are subcrestal on the palatal aspect because of the bone loss on the buccal aspect. So now I'm placing a cover screw because I'm not going to place a healing abutment in this case. So see the parallelism. Every time you have to check for the parallelism. So now I'm extracting 1 3, that is upper right canine. Here also we have a bone loss on the buccal aspect, but in this case, immediate extraction cases, you have a predetermined path, but some cases you have to change the path. So right now I am changing the direction a bit because canine was drifted mesially, so that I am correcting the direction. Now you have to check for the dehiscence on the buccal aspect of the tooth. So with the probe I am checking whether there is a dehiscence or not. But with the help of CBCT we have seen. So immediate extraction cases you don't need much of osteotomy. So directly you can place the implant. Here I am placing the dentition implant. So first the implant was slept distally, but again I corrected the direction so that I can be parallel to the adjacent implant. So sometimes radiographically we cannot judge whether it is parallel or not, but clinically we can see it is almost parallel. If you are doing a guided one, you can have a predetermined parallelism, but clinically you have to check intraorally that you are parallel to the adjacent tooth. So here also I am getting almost 30 to 35 ncm of torque, and again I am equicrestal on the buccal aspect and subcrestal on the palatal aspect. So see, it is almost 35 to 40 ncm of torque. So this is quite a good torque in the maxillary region because maxillary bone is more porous. Now I'm placing a cover screw. So see, it is almost parallel to each other, and on radiographically you can see it is subcrestal, but it is equicrestal on the buccal aspect. So we'll be starting with the suturing. I'm just fast forwarding the video here just to get an idea. So you should give a watertight suture. So in the canine region, we have to pull the gingiva and close the socket. Now I am giving figure of 8 suture in that region so that I can close it properly. You can see we have closed it. So that's why I given the vertical incision initially so that we can cover the implant. Now I am giving suture in the region of vertical incision. So in the region of central incisor, I am placing one suture. So there was a bit recession in that region initially. So I am giving a good tight suture in that region so that we can cover the roots of one. So can you see we have completed the suturing. So we'll take one OPG. Here you can see these are almost subcrestal, but it is equicrestal. So thank you for watching. Do contact us.